Thanks. Well, good morning. So thank you very much for the opportunity. It's actually interesting that one of my former graduate students, when I taught at SCSU, is Julie. So it's good to see her back. Good to see that she paid attention. So this is what I'll talk about in the short time I have. This will be sort of a broad overview of aging, and particularly, hopefully, convincing you that this is going to be a growing problem by virtue of demographic trends. And so I won't necessarily touch on kind of what we do about elder abuse, but just to show you that what you do increasingly will become important. So I'll talk about the history of aging and show you some of the current slides about the demography of aging. Talk a little bit about the biology of aging and why we age, just for, I think, our own benefit, and then talk about how these trends intersect with the whole concepts and risk factors for elder abuse, and so what those risk factors are. So I usually like to provide a little bit of a historical basis for talking about aging, and I usually start off with Aristotle, which we all learned in high school was a very important person, but also not one who is particularly kind about older people. So this is from a kind of treatise he wrote about aging, and he said about older people, they have lived many years, they have often been taken in, they have made mistakes, and life on the whole is a bad business. The result is that they are sure about nothing and they underdo everything. They are cynical, they tend to put the worst construction on everything. They're small-minded, not generous, because money is one of the things they must have. So this actually goes on for pages and pages. So he was not particularly somebody we would call a happy gerontologist. And so one of the reasons why, and I think a lot of these sort of negative attitudes continue today, and at the time, aging was thought to be kind of an intrinsic process. It was like a kind of essentially the metaphor, and actually it wasn't really even a metaphor, it was a real belief at that time, was that aging was a drying and a cooling of the body. So the only thing you could really do about it besides staying away from older people would be to add heat and water. So that's one model of aging that's thankfully gone, but not completely gone, because I think there certainly are negative attitudes that persist. I would just provide a little bit of a counterpoint, and we kind of at the Stein Institute focus on healthy aging, sort of the opposite in many ways about what we're talking about today. But there are people in the old literature that talk about some of the positive aspects of aging, and I would encourage anybody to read the essay, which I won't pronounce, but in Latin, but it means On Old Age. And he really systematically refuted a lot of the arguments that previously had been made about aging. So, for example, one can pursue active pursuits. You may not be able to pursue active pursuits, but you can fulfill advisory functions, or that if your memory is impaired, if you do not exercise it. For one example, he says that old man never forgets where his treasure is buried. So there is not necessarily a disease process that has to do with aging, but that aging is really determined by behavior, and I think that's a theme that will continue. So the solution really is to sort of adapt, and I think that's what a lot of our aging services do, is help people adapt to physical limitations. Okay, so now let's skip ahead a little bit in terms of what's going on currently with aging. So we've witnessed a pretty remarkable demographic transition in the last 150 years. So there is the age distribution in 1900. I don't have a laser pointer, but I'll sort of point. So essentially each of those bars represents the proportion of the population. So in 1900, only a very small sliver of the population was over age 60. In the 21st century, it becomes a rectangle fairly quickly. And as you notice at the top right, that actually skews towards more women. And to sort of give you a sense of the volume of this change, there are now more people who are older than age 60 than there are children for the first time in recorded history. And it's been said that 2/3 of the people who are older than 65 are actually alive, who have ever lived, are alive right now. So that's pretty remarkable. So we've really changed in a fairly short amount of time. Here's what the situation looks like in Japan, just out of like where these effects are exaggerated, just to show you projections. In 1950, the population looked like a pyramid, and in 2009, it's a reasonably much like a rectangle. In 2050, it's going to be an inverted pyramid. So there are going to be an incredible number, the majority of people will, in a sense, be at least over age 50, and a fairly large chunk are going to be older than 60. So this is a big change. Not only have we changed with respect to the demographic sort of distribution, the actual way people look has changed. So in 1850, the average guy, the average male, this is actually coming from Civil War studies from a guy at the University of Chicago named Robert Fogel, who's gone back and looked at the medical records of people in the Civil War and looked at their descendants. And so the average Civil War Union Army soldier was about 5'7" and 150 pounds. That was only 150 years ago. In 150 years, he's put on 2 inches of height and about 50 pounds. 50 pounds good because, in this case, obviously, we've kind of overcorrected for that. But this guy on the left was subject to malnourishment and had very little in the way of protection from infectious diseases. So we've really changed the way we look. And along with that, a lot of the diseases that we get that are associated with older age, that are age-associated illnesses like heart disease, arthritis, cancer, which is a neoplasm, respiratory problems, we get later. So the health span has increased as well, which is good. We want that. But what happens is that it gets pushed out further. So I'll show you how that works in the next couple of slides. But I think it's good to sort of just, and certainly in thinking about the conditions of life and how they've changed for people who are older. This is what it was like in 1850, if you made it out of infancy, you're about 75% chance. You had about 60% chance of making it, only 60% chance to making it out of your teenage years. The thing that was going to likely kill you was an infectious disease. We've now limited that quite a bit. People spent a lot of their money and resources on 2 things, food, clothing, and shelter, or 3 things. And now we only spend a small amount. And so 3,100 hours of work per year. So people actually worked harder at that time and didn't have vacations or leisure time. So certainly to be thankful that those conditions have changed. So that's pretty rapid. So we're talking about 2 generations. Okay, so what about the current state of aging? And so here's the slide from the census. So this is from 2010. And I think the bottom line here is that there's a pretty sharp curve here. So we're seeing in terms of the number of older adults. So by the year 2050, about 100 million older adults. And so the bottom line of my talk is that even if we do nothing, or we keep doing the great work we do with elder abuse, the number of cases that will occur, the incidence of elder abuse, will have to follow that unless we accelerate the efforts that we're talking about today. So this is a map showing the proportion of the population the number of people who are counties with the number of people over age 65. So as you can see, the darker colors are for higher proportions. Actually, San Diego does not necessarily have a higher proportion of older adults than the middle of the country, which is actually maybe perhaps a little surprising. So you might ask, why is that? It turns out that it means that basically a lot of the young people in the middle of the country have moved to the coasts, right? And so who's left are older adults. Nonetheless, you can see in the middle of the country up to about 1/3 of people are older than age 65. And we expect that trend to continue. So the good news, if you are 65 and you're a woman, you have around 20 to 25 years expected life left to live, which is quite good. unfortunately, in the United States, we're not the best at this. Japan is the best with respect to years of life in terms of longevity. So we're kind of in the middle there. As you can see, these trends are increasing between 1980 and 2009. So we are expanding the life expectancy. This doesn't speak to necessarily the health span, but it has followed a little bit of the same curve, although not to the same extent. What about for men? So this is keying this to between 15 to 25 for women. Men are not quite as fortunate. And there's still a lot of debate about why women live longer than men, but there are some interesting theories about that. But you see about 15 years around the same sort of trajectory with respect to the number of years left to live in terms of increasing. And again, the United States is not exactly the leader in this. So here's, I think, one piece to consider when you're thinking about who's going to be the older adult of the future. So this is 2010, and as you can see, the rectangularization is sort of happening on the far left with Caucasians, but on the far right, you see among Latino segment of the population, they're the fastest growing segment of the older adult population. So that sort of pyramid is going to turn into a rectangle based on the demographic shift, right? So they're sort of going to be the older adults of the future, particularly in San Diego. So I think the need for services to address their needs and to recognize elder abuse in that population is quite important. All right. So I'll step back a little bit and just try to address the question of why we age. We still don't know, and that's kind of the amazing thing. We've been trying to figure that out for thousands and thousands of years. But it is kind of interesting when you look in nature and you sort of look at the lifespan of different creatures. You could sort of see a lizard and a mouse, and you can see what their lifespan is. And you could really sort of think of a turtle as a lizard with a shell, and a bat with wings is basically a mouse with wings. So what's remarkable is the lifespan differential between these species. So about 50 times longer. So something is kind of controlling the rate of aging. And so we're obviously not going to grow wings or shells, hopefully, or maybe it would be good, but I think the idea is that there is something that's controlling the rate of aging, and potentially we could figure that out and do something about it. But that's been particularly challenging. Otherwise, we would all be taking some drug that would do that. All right, so when you think about longevity and how long we live, one of the first things you hear is to choose the right parents, right? So to choose choose parents that are going to live long and have a good set of genes that will carry you into later life. So what proportion of your longevity is really due to genes? Well, we know that from twin studies to a certain extent. So among monozygotic twins, ones that are identical twins versus ones that are fraternal, we can calculate the discrepancy, and basically by plotting lifespan of one of the twins versus the lifespan of the other twin. And you can see on the left, those dots are a little bit more bunched together. And in the second, to the middle graph, the fraternal twins, it's pretty spread out. So that suggests that there isn't really much relationship between how long you live, what twin 1 lives, what twin 2 lives in the dizygotic twins, the fraternal twins. The monozygotic twins, there's a little bit more bunching together, but not that much. So basically we can conclude from this that around 20 to 30% of how long you live is due to heredity, directly to heredity, to genes, so what you're born with. So that means that a lot of the variability has not to do with what you're born with. And so there's a lot of impact of things that happen after you're born, which is important, I think, in terms of how we promote healthy aging and prevent the things that impact it. Just to give you a frame of reference, your height is around 90% heritable. So you're pretty much almost all determine how tall you're going to be by the time you were born. Another interesting set of things when you think about genes, and just a couple more biology-based slides, is that one of the interesting things about aging is that a lot of it occurs after the point at which, at least among women, you've reached the maximum reproductive age. And so that means that in terms of thinking about what gets selected out of the population, what diseases and problems get selected out of the population, we don't really have protection, in a sense, from that. So in a sense, this period after age 50 or so is kind of beyond the warranty period, in a sense. You can think about that we're sort of living without the protection of evolution, and that makes it difficult to study the effect of how genes interact with any sort of observable phenotype in older people. And then lastly, there is some amazing research out there that suggests that we still just have very little handle on why we age. This is a data on worms. And so we know a lot about worms and how they age because they're a particularly good organism and a pretty simple organism for that. So this is an experiment where they took worms that were genetically identical, and then they kept them in the same jar, in a sense, and had the exact same situation. So you'd expect that they'd all pretty much live about the same time because it's the same jar, same genes. However, they had huge variation in lifespan. So that really suggests that there's something going on randomly. It's probably not having to do with what goes on in the jar in terms of how many push-ups they're doing in there. It has to do with just sort of a random set of factors that we really have a little handle on. So I think when you hear about things that have to do with anti-aging, it's particularly complicated, even more complicated than we'll know, based on if we can't figure out how to change the lifespan or modify the lifespan of worms in a jar. So in terms of just the current thought of why we aged, one of the original theories was to try to prevent kind of population overgrowth, right? So if none of us passed away, the highways would be very crowded, and we would be in long lines everywhere. So maybe we're just trying to kind of keep the population at a kind of stable rate. And actually, that theory, in terms of hundreds of biological experiments, suggests that really there isn't much evidence of that. So it seems like for the most part we're programmed to survive. And the things that sort of lead to our demise are a couple of things. One is that we kind of accumulate a lot of mutations and errors over our life. And so the metaphor there is kind of like a car. The harder you drive it, the more likely it is to need repairs. And you accumulate mutations through toxins and other types of exposures. The other side of that is that your repair shop, the part of the body that sort of heals itself, also ages. And so you're less able to change the damage that happens to your DNA, and you're less resistant to stress. Each of these is kind of necessary but insufficient in terms of explaining the entire aging phenomenon. But nonetheless, the idea is that if we could figure out some of these things and come up with treatments, we could hopefully slow the pace of aging. And just, I think, a particularly somewhat depressing slide to think about is that one is when you always think about when do you age and when should you start doing something about it. And you probably should have started a while ago. I don't think there's too many people under 20 in this room. But for the most part, you've been aging for a while. And so we need to sort of think about how you can modify those factors at an early age. So your flexibility and your balance peaking at age 13, your muscle strength at age 18, tissue repair at 13, and so on. It's a good depressing slide for you. So that's a long way of getting to the idea that essentially there's a long-running set of debates around what aging is, and then the one thing we do know for a fact based on these slides so far is that there are going to be a lot more older adults, and that genes, in a sense, have something to do with how we age, but a lot has to do with the factors that, and the sort of environment we are currently living in, if you think about it, our jar that we're living in. So let's shift to elder abuse, certainly more relevant to the day here, and talk about the risk factors for elder abuse and what's happening with those. So, you know, we know a lot about the demographics of aging in general, from the census and other types of sources. We do not know a lot about the demographics of elder abuse. The probably best study that I was able to identify is the National Incidence of Elder Abuse Study, which is quite a bit older now. There's probably other sources that I'm not as aware of, but I think this provides some sense. And so at that time, there were around 236 reports of elder abuse in the home. We're focusing on in the home within a year, and then 50,000 reports of elder abuse in the nursing home within 1 year. So in terms of that incidence across the US, that seems quite low, right? But I think the main issue with doing the demographic understanding of elder abuse is that it's really estimated that only about 1 in 5 cases are reported. And so if you sort of multiply 236,000 by 5, then we have 1 million cases. And then we're starting to really talk about a fairly, almost like an epidemic event. And so when you also consider that in 1998, we've probably added another 20 or 30% more in terms of the population of older adults, we're getting almost into the 1.5 million cases. So this is a big deal. And I think just in terms of understanding, in terms of a scientific understanding of elder abuse, the fact that we can only estimate that and know about only 1 in 5 cases from a scientific standpoint means that we still need a lot more information about it. Nonetheless, in terms of what we kind of do think we know, the risks for elder abuse is increased among women, the older adults being over age 50, those who are diagnosed with dementia or a mental health problem, and those who are socially isolated are those with a caregiver in the home. And I think those all kind of make sense. And what do we know about the trends with respect to each of those? We've already talked about women being particularly a growing population, older women. The fastest growing segment of the population are those who are older than age 60, over age 80. And even faster are people who are older than age 90, and even faster 100 years old. And I'll talk about the other factors as well. So let's see, I'm going to show you some slides from the recent census, which I think sort of tell a story about where these trends are going. What about living situation? And I put these in the file, and I'm happy to share these slides with you in case they're helpful. But the proportion of men and women who are, the distribution is fairly broad in terms of people over age 65. Most people live in the community, and a fair amount of women in particular live alone. And that differs pretty substantially by ethnicity, with Caucasians being more likely to live by themselves. So women are more likely to live by themselves, and then with spouse, men are more likely to live with spouses than women, mostly because without spouses, men typically don't live very long. And that's been a true story from the gerontology literature for a while. So what about some of the other risk factors? We talked a little bit about mental health symptoms. And so depression is one that's tracked by the Health and Retirement Study, which is a long-running study out of the University of Michigan where they followed older adults, a population-based sample of older adults. So in addition to being more likely growing part of the population, women are more at risk for depressive symptoms, and that's true across the lifespan. And so this is the actual national trends. If you look on the bottom right there, around 18 to 16% of older women have clinically relevant depressive symptoms, and that's defined as having 4 or more symptoms on the Center for Epidemiological Studies depression scale. So this would include problems like sleep, appetite changes, and so forth. So not maybe a full diagnosis of major depression, but yet and still enough symptoms that it should be calling to the attention of their healthcare providers. And you can see these trends are reasonably stable. So between 1998 and 2008, there hasn't been much done with respect to change in the national prevalence of depression. What about with respect to the proportion of people who have these sets of symptoms by age group? And among the highest risk, actually, if you wanted to look, and there's a whole another sort of set of data on aging and depression. Actually, the period of life where you're most at risk for depression is your young adulthood. And so older adults have lower rates of depression by and large. However, there is kind of a bump among older adults, so those over age 85. So around 10 to 12% in the 60 to 65 range, and about 20% in those over 85. So that's a pretty substantial subset of the population in terms of the risk factors that we talked about before. I think it's usually, I mean, from a mental health standpoint, it's particularly valuable to think about how depression in and of itself can intersect with all of the factors that we know that promote a healthy, longer life and a health span. So if you're depressed, you're less likely to get exercise. You typically have a worse diet. You don't have as much access or energy for cognitive stimulation to keep your brain healthy. You're certainly less optimistic and probably don't feel like being around other people. And your attitudes towards aging and your ability to sort of manage stress are also diminished as well. So it's a pretty blunt and sort of broad impact on all the things that we know that promote a long and healthy life. And so I think it's particularly important to recognize depression as a risk factor for general aging-related problems, and as we saw before, for elder abuse itself. What about disability? And so this was one of the other risk factors. This is the proportion of people who have at least one impairment in an instrumental activity of daily living. So whether they have either some 1, 2, or 3 to 6, and around 40% in the population over age 65 have that disability of some sort. And what's interesting about these data is actually these are actually declining, although slightly, but are declining. So there is a larger number over age 65 of people, or a bigger proportion of people who are age 65 and over who are not disabled than there were in 1992. However, the number of people who are disabled and over age 65 has increased at the same time, if that makes sense. What about cognitive impairment? That was one of the other issues. And so this again is from the health and retirement study looking at the proportion of people with moderate or severe memory impairment. And so this was based on a word learning task, so recalling fewer than 4 words out of 20 that were given to some. So somebody asked them to remember any of 20 words, and they only could recall 4. And so that would be considered moderate or severe. And as you can see, age is a huge risk factor for cognitive impairment, with the population over age 85 approaching about 1/3 of them with some fairly moderate or severe cognitive impairment, memory impairment, which is typically co-occurs with other cognitive impairments. As you can see, men a little bit more likely to have cognitive impairment across these age brackets towards the latter half. So this is certainly a problem that has to do with reporting, right? So if you can't recall what happened, it makes for a difficult system. So another, I think, factor that wasn't listed, but the idea of income. So one of the interesting thing about, from a financial standpoint, is that older adults are the richest and the poorest people in the United States. And this is just data from, again, the census that shows that on the left, the people who are in the lowest fifth, the lowest quintile of income have their income really restricted to one source, and that has to do with Social Security. And so that's about it. And so you can see that huge blue bar on the left. On the other side, people who are in the highest income have very diverse sets of income. So they have much more flexibility and less reliance on one source, which could be controlled by someone else if you're thinking about financial abuse. But they get money from pensions, asset income, Social Security, and so forth. In some ways, they're both at risk, right? So people with the lowest fifth may have fewer options in terms of changing their lifestyle if they are restricted, or if they're at risk for some financial abuse because they have one source of income. On the other end, you have people who have a lot of money and maybe at greater risk as a result of that as well. So I'll just close with a couple of slides looking at social isolation. And we've done a number of studies looking at kind of how people experience their time. And so, which, without getting into the methods a little bit, but when these kind of data are useful in terms of ascertaining how people appraise what they do on their daily life. For example, when you ask people when they're happiest, they usually say it's when they're with their kids. However, when you look at these data, which actually asks about what you're doing and how you're feeling, usually that's when you ask people in that way, when they're with their kids is when they're the most stressed and the least happy. And so these data kind of hopefully get to the marrow of kind of how people really experience their time. And just a couple of slides. One is that we know that one of the big risk factors for elder abuse is social isolation. And at least in these data, older adults spend around 60% of their time by themselves, whereas younger adults only around 40% of their time. And if you cross-tabulate that with happiness or positive emotions, you're actually happiest when you're around other people, and that's true throughout the lifespan. So certainly being here today is an example of that. There's one exception to that. So if you're older when you're younger, you're actually happiest when you're with your spouse. When you're older, you're actually happiest when you're around anyone else. But it's still better than being by yourself, which is nice. So, okay, so let me sort of wrap up, and we can hopefully have time for some questions. But the take-home points are really that I think, if I get nothing else across, that the incidence of elder abuse is very likely to rise because of the demographic shift. Even if we do all the great work we can in terms of the prevalence, in terms of keeping the prevalence steady, there's just going to be a lot more older people unless we can change the risk factors of elder abuse. And those risk factors are fairly broad, and there are seemingly a lot of them, particularly the distribution of men and women, of women, cognitive impairment, depression, and so forth. Those are not necessarily changing over time, and probably won't for the near term either. We still really don't know why we age, but we do seem to be rapidly changing the influences on aging beyond genes and choosing the right parents. And so that trend will also continue, so we should expect that might accelerate as well, so even further accelerating the demographic changes that we saw before. We know a lot more about aging in general than we do about elder abuse, likely and most notably because of underreporting. So there really needs to be a better system of data collection and reporting that we can actually use to understand the risk factors and then act on those and develop really targeted interventions around that. And then lastly, the risk factors of elder abuse are common and stable over the recent past, and so I think any efforts that we are doing now, we will need to increase or step up due to this demographic change. So I'll say thank you for the kind attention. These are the folks at the Stein Institute, and I'll be happy to answer any questions, so thank you.
There is an increased rationalization of why life should be terminated before the natural causes of life terminate life. And it seems increasingly that with Obamacare that's going to be taken out of the control of the individual person or person's relatives.
Yeah, I don't know if I can necessarily comment that. I would say that there's sort of a movement towards trying to change the way we think about sort of this values-based medicine and sort of thinking about how to quantify services in terms of their impact on improving people's, or sort of preventing rapid declines in quality of life versus length of life, per se. And I think the challenge there is that quality of life is particularly subjective and individualized and very difficult to standardize and to really probably allocate services based on any sort of a kind of common metric. I'm thinking I work at the VA, and I think there's some interesting data around sort of things, subjective things like patient satisfaction. So there's some movement towards improving, sort of billing people based on how satisfied patients are. However, when you look at patient satisfaction, they're not necessarily, people who are more satisfied with care are not necessarily getting better care or don't live any longer. So I think, or not any healthier per se. So I think the whole treatment of subjective kinds of aspects of these measures is really an interesting area.
One more quick question, real quick.
All right, well, thank you very much. I really appreciate it.
Here's a little gift.
Oh, thank you.
For our appreciation of your hard work.
Great, thank you.
For your support.